Hey guys, welcome to Tuesday Talks with the Green Bay Doulas. I'm Emily Jacobson. I kept Sara here, so this is Dr. Sara Swift, and we want to talk about directionally challenged babies.
That's a good name for this talk. So about 4% of babies at full term tend to be breech. So what that means is that instead of being this way, babies for some reason are bottom down. We know that babies that are bottom down have a little bit higher chance of having something wrong with their hips. And we don't know if it has to do, is it that's how they were made, or is it just because they've been sitting. So here's my pelvis. Here's the front, here's your tailbone. This baby's kicking me here. And the typical baby at about 35, 36 weeks should be settling down just like this. Well, sometimes that doesn't happen. And what your doctor or midwife will do at your last few visits is they will feel for the head. And so right above the pubic bone should be nice and hard. Sometimes we are fooled because sometimes baby butts are a little bit bony. So we have been known to miss a few every once in a while, but if we are not sure which way's up and which way's down, we can always do a quick ultrasound to make sure that baby's head down. The problem becomes that we don't usually like to deliver them breech. And the reason behind that is that there's a study that came out probably 20 years ago now that showed an increased risk of bad outcomes, meaning babies would get injured or they would die if we delivered them bottom down. And that had to do with the head getting stuck because, as you know, babies have a big head. We've all felt that. So what do we do if baby is breech? Now,
Have a moment to cry.
that's totally okay. There's a few things. So there is a lovely website called Spinning Babies that I send everybody to. Has more to do with positional things, hands and knees, putting your tush in the air, things like that.
And all our doulas have taken Spinning Babies, and actually this May 16th and 17th, we're bringing Spinning Babies to Green Bay for a regular course and an advanced class for those of us who already have taken the intro. So, very exciting.
So that is one option. The other option is that there may be some evidence that chiropractic care may help with realigning the pelvis and get babies to move. I don't have much experience with that. This baby wants to kick me. But the thing that your obstetrician can do is an external cephalic version. And what that is that we actually, from the outside, we bring you to labor and delivery, usually give you a medication in your, that baby was overachieving, give you a medication that relaxes your uterus called terbutaline. It causes you to be jittery and your heart to race, but it does relax the uterus. And then what we do is we make sure baby's still bottom down, and then we put a whole bunch of gel on your belly. And then what I do actually is I, from the outside, raise your baby's tush up and either try to spin the head one way or the other. Sometimes it requires two people, sometimes just one, and the goal is that we actually flip the baby from the outside so that it is head down. Now, things that go into when is it more successful is if you've had a baby before, if you have a fair amount of fluid, and if your baby is not huge, which is a reason we try to do it somewhere around 36, 37 weeks, because after that we start getting a little spatially challenged in the uterus as well. And if your baby flips, great. Sometimes these little boogers tend to flip back. And there's nothing to say that we couldn't try to flip it again. Usually after a water break, so it becomes pretty hard to try to flip it again. But up until that moment, if you have a really stubborn baby, we can sometimes wait till 39 weeks, turn the baby, and then start an induction to make sure that baby will stay that way.
I've also seen success with acupuncture and moxibustion is another thing that some people have said has worked for them. And physical therapy sometimes in conjunction with along the lines of chiropractic, is it different ligaments that are holding up the uterus from being able to prevent baby to move too. Right. So
if you are preterm, your chance of having a breech baby is a little bit higher, which is just the fact the baby hasn't made it down. Things in the uterus that can make it more difficult for baby to turn around are things like a septum or bicornuate uterus or muscle tumors like fibroids.
So the bicornuate uterus means a heart-shaped, two lobal.
Yes.
It's kind of hard.
It
Doula speak. See, that's why we work so well together. I translate. All right.
There's that. If your baby does not turn, then we have to talk about whether we do a C-section or if we go for a breech vaginal delivery. Now, unfortunately, many of us have not been trained in breech vaginal deliveries. There's a few physicians who are very comfortable with that in a well-selected patient. And so, unfortunately, majority of the time, you do end up with a C-section. Mm-hmm. Now, if we're talking about twins and your first baby's head down and the second baby's breech, that's a whole different thing. And oftentimes we can do what's called a breech extraction, meaning that I reach in the uterus and grab your baby by the feet and bring it out that way. But
delightful. Some say that's better than a C-section, though. One being born vaginally, one being born via C-section. Right. Can be really traumatic sometimes for mothers.
Majority of women who have a breech extraction do great, and these babies do great. They're a little shocked after I reach up and pull them by the feet because it goes pretty quickly. But it is a great skill for your provider to have and a great way to avoid a surgery. But baby A needs to be head down and it needs to be twins, so we cannot do a breech extraction on a singleton pregnancy.
Okay. What other divisionally, I call them cattywampus babies. Asynclitic would be the terminology.
So in an ideal world, we would like every baby to be facing the mom's spine, just because it is easier for them to navigate the birth canal that way, because they tuck their chin and they kind of do this, mm-hmm. Whereas if they come back this way, this is a little bit more of an awkward. And so sometimes we call that occiput posterior or sunny side up.
Yep.
And oftentimes that has to do with the shape of your pelvis. So if you have a baby who's facing this way, meaning it is coming straight out at you, oftentimes pushing time seems to be a little bit longer.
I see contraction patterns are much more little goofy, yeah.
Things that we can do to help baby rotate from a sunny side up to kind of the right way is we can do position changes. There's some positioning devices that we can help with that. Mm-hmm. Or your provider can actually reach in and manually turn the baby. And so oftentimes not super comfortable for mom, but sometimes really helpful in achieving a sort of a better labor progression. Other ways that babies come out sometimes is face first. That is not a great way to come out. Mm-mm. It is possible as long as the chin is facing the right way, but remember that impact of that contraction in the pelvis oftentimes will leave the face fairly bruised. It's a little bit easier for smaller babies to come out that way, but because if we look at this baby here, this diameter is way bigger than this, that labor tends to be pretty stalled too. So oftentimes if they come out this way, they will not fit. Sometimes we're able to tuck their chins. Other ways that babies like to challenge us is that they can... This baby has kind of short arms.
The Superman.
Yeah, the Superman. Oftentimes babies will pull that hand back, so not the end of the world, but I have seen a few babies come out like they have a question for me. But that arm tends to be pretty bruised too. I've actually seen a foot in front of the head too.
Interesting. Yeah. Wow. Yeah, so babies come in all different ways, some more challenging than others. But there are ways that where you can work with your medical provider to figure out what's the best way for both of you guys. But thank you. Appreciate it. That's all I got. We'll see you next week. Bye.